Patient in their 70s with history of colon cancer, presented with neck pain. So we do this cervical spine actually as an outpatient, but we should be on the radar to look for any metastasis in a patient with history of colon cancer. Although it's just not very usual to have it in the cervical spine, but as we see here, we see that this sequence on the left is a sagittal T2 through the cervical spine. The image on the right is just T1, and the way I know is because like all the CSF is dark, and then we see the bone marrow is bright, and also we see the fat is bright. So that's how we know this is a T1 sequence. This is a actual T1 fat SAT post contrast. We see all these fat are suppressed, and then we see the vasculature that shows this is a T1 fat SAT post contrast, and image on the right bottom is going to be sagittal T1 post contrast sequence. So what we see here, so one of the most important sequences for looking for metastasis is just T1 sequence, that this normal fatty signal of the underlying marrow is going to be replaced by tumoral cells. So as we see here, this C7 vertebral body is completely replaced by the tumor cells. It's just all dark. It also involves the posterior elements, spinous processes, and also has extraosseous extension. And if you look closely on this post-contrast sequence, it also involves the spinous process of the above and below vertebral. So it involves the C7 and C6 and T1 as well. And there is like some sort of extraosseous extension as well, that usually these tumors have some extraosseous soft tissue component. What is really important here is when we want to report this entity, it's just not enough to just say there's metastasis. We have to say other important relevant factors that change the management. So first of all, so we know that there is also metastasis involving the C7 vertebral body, posterior elements, also adjacent spinous processes. We know there is no acute pathologic fracture on this level, but we see that there is extensive extraosseous extension throughout the surrounding soft tissues, and also we see there is, the most important finding is epidural involvement. So we have this epidural metastasis within posterior aspect of the cord that is extending from C6 to T1 and causes cord compression. Although I don't see any abnormal signal at this point, but this is a severe cord compression and severe spinal canal stenosis that can cause patient symptoms right now. So this is just kind of neurosurgical emergency. They have to go and just resolve this, or they do radiation as quick as possible in order to release this cord compression. And then when we look at the actual sequence, we look for foraminal involvement. So when they do radiation, they should make sure they include all these in the radiation field of view in order to just decrease recurrence rate. So we see this, the left C6, C7, and C7T1 neuroforamen is also involved with all these tumor, and these are the all tumor involvement that we saw in the sagittal sequence. If we look at the T2, at the level of like the most important stenotic level, which was the level of the C7 vertebral body, we see this complete effacement of the CSF and cord compression. So these are important findings that we have to talk about: osseous metastasis, extraosseous extension, epidural involvement, and foraminal compromise.